Thank you very much. I have any questions? I think it's what you presented about the prevalence and the decreasing of the prevalence is very important. But to avoid any confusion, when you're talking about angioscan, you don't talk about calcium score. It's imaging by coronary scanner. It's okay?
Yes. For the sake of time, I did not talk about calcium score because I love the calcium score, so I'm already biased anyway. There are two different CTs. The one is the calcium score. It's also in the guideline. It says if there's a low pretest probability and the Eggleston score is 0, you don't really have to go on. But the one thing, the slide I showed you, is CT with contrast agent to look for coronary stenosis. And if you see coronary stenosis, the CT may overestimate the degree of stenosis. But if you see normal coronary arteries, and this is the strength for rule out, you are pretty much sure that there is really no stenosis.
Mm-hmm. In acute coronary syndrome, you still have to prescribe triple anticoagulation for at least 1 month. Are you okay with this? For the first month after stenting or after an acute coronary syndrome, do you have now to give a triple 3 anticoagulation?
Well, you mean in patients with atrial fibrillation and stenting? Yeah.
No, in acute coronary syndrome during the first month.
I would not routinely give triple therapy in patients with sinus rhythm acute
syndrome. What do you give?
We give usual dual antiplatelet therapy of aspirin plus ticagrelor or aspirin plus prasugrel. But in the last years, actually, prasugrel was falling behind. But I think this nice study showed that at least we should use more prasugrel, especially since in some countries it's already generic. So you may save costs by not harming the patient, and I think that's a good way.
Okay.